Newborn screening webinar. We're very happy to present the Sickle Cell Disease Screening Forum for newborn screening for Victoria. I would like to acknowledge the Victorian Department of Health for their support and funding with getting this screening implemented for the babies of Victoria. I'd also like to just shout out to Swanisha, who's working behind the scenes here, and of course Team VCGS and teams at the RCH and Monash for their support with the sickle cell screening implementation. I'd like to also acknowledge the traditional owners on the land on which we're meeting and pay my respect to elders past, present and emerging, and wish all people, irrespective of their background, to have equal health, access and outcomes. Tonight, we're very privileged to be joined by Dr. Anthea Greenway, who is an expert in sickle cell disease screening. And Anthea works at the Royal Children's and at Monash and is a director in the hemoglobinopathies area. We're also very fortunate to have Dr. Mercy Thomas, who is one of our newborn screening educators, and she is going to talk to us about recollections. My name is Rhonda Greaves and I'm introducing and chairing this webinar tonight, and I'm in the newborn screening laboratory and I'm a clinical scientist. If you have any questions during the session, I'd encourage you to put them in the Q&A button. There is a button at the bottom of the screen. We're aiming to give a fair amount of time to have a question and answer session at the end of the 3 presentations. To help facilitate outcomes from the tonight, we have some learning objectives, and we've got 3 of these. And the top one is for you to be able to discuss sickle cell disease screening with new mothers of babies in particular, and to understand the follow-up process associated with a screen positive result and why it is really important for a few babies to have a 3-month follow-up recollection. And this is a change of process that we will talk to. Now, I'm just going to step back to newborn screening. It is really exciting for us because we've got our 60th birthday this year for newborn screening for Victoria. And over those 60 years, we have screened 3.9 million babies in Victoria. And on this graph, you can see how we've gone about our implementation, starting with PKU back in the early 60s out of Kew cottages. A decade later, congenital hypothyroidism, then cystic fibrosis, and then our metabolic panel. But you can see what's happened in the more recent years, starting with CAH screening, and we have our most recent implementation of sickle cell screening, is that we have had a massive increase in the diseases or conditions screened for. And this has obviously been challenging for the labs. It's been challenging for clinicians as well. It's been challenging for maternity service providers. So we're really grateful that we're all working together to get all of these new conditions in. But tonight we hear about sickle cell, which is our most recent implementation, which officially went live in February this year. And we have been background live since September last year. So this comes out of a federal government initiative where the federal government has looked at expanding the newborn screening program. And these are on the website for the government, and you'll see that sickle cell disease screening is one of a set of conditions to be implemented. And on the second column from the right, you'll see the Victoria implementation progress and plan. And you'll see that we've implemented sickle cell, so we've got a big tick, and we've led the way in this, and the other jurisdictions are close behind, so they'll be doing this as well. This was formally recognised as needing to be introduced on the 25th of September 2024. But of course, as for all conditions, We started working on our plans back in 2022. And we're lucky with the support of the government, as I said, in all of this and everyone involved. A couple of quick picks from our laboratory, and we have a 2-tier screening process. So we've had to get new instrumentation. This is a brand new condition. So we've had lots of learnings. And we're looking at screening for target conditions. Excuse me. This thing, babies that have sickle cell disease or that are compounded with other forms of hemoglobin disorders or variants. And so these are targeted by the Commonwealth Government. We also have a number of non-target conditions, and these are the beta thalassemias in particular that we can find in our presentation. So on that note, I'd like to actually finish and hand over to Dr. Anthea Greenway, who will come in and present on sickle cell disease screening. Thank you.
Thanks very much, Rhonda. Can you guys hear me?
Yes.
Great. I'm just going to share my slides. Great. Can you guys see my screen?
Yes.
Great, fantastic. So thanks very much, Rhonda. My name is Anthea Greenway. I am a paediatric haematologist and I work at both the Children's Hospital and Monash Medical Centre. And I have a special interest in looking after patients and families with sickle cell disease and beta thalassemia, so that group that we call the hemoglobinopathies. And it's my pleasure to talk to you guys today. I'm really aiming to just give you a little bit of background information so that you would feel a bit more comfortable talking to families if they happen to see any of the printed information or ask questions about what sickle cell is. They may not have heard of it. That would be fairly common. But so you could sort of answer those questions and really think about how you might phrase that to the family so that they know why this is an important condition to know about. Okay, so just to start off, sickle cell anemia is a multi-system disease. So it affects all the cells of the body, so it's sort of top to toe. And one of the ways we sometimes talk about sickle cell is it's a bit like a diabetes. It affects all the vascular bed. So it's a really important thing to know about in a child. And in the era where we haven't had newborn screening, that's been challenging because we have certainly had cases where patients have presented and we've not known they've had sickle cell disease, and not having that information is really critical so that we can provide the best care for the patient. So the introduction of newborn screening has come with lots of advocacy from our patients and families and our patient support group, but it also brings us in line with the UK, the US, and many of the European countries who've all been performing newborn screening for sickle cell for a number of years. The reason it's important to know about is it's a condition that has episodes of acute sort of severe illness, but there is progressive or end organ damage. And so it's in that setting that we know that when we can detect that a newborn baby is at higher risk of sickle cell, and as we've just heard, we'll have information from first and second tier testing that will suggest that allows us to get that family into clinic to give them some education about what the symptoms might look like, and to get them on prophylactic antibiotics and get them really on the path to really good health care to try and prevent some of this end organ damage that we know can happen. The reason it's important is the incidence has certainly increased significantly. So when I was a trainee, which, you can see my grey hair, was a few years ago, we had a handful of patients with sickle cell. And now in our centre in Melbourne, so at the Children's, we have nearly 100 patients, slightly less numbers at Monash, but across Australia, increasing numbers. And one of the challenges with this condition is that one of the changes in sort of incidence is that WHO are predicting we're going to see 30% more patients by 2050, which is not that far away. And patients now, particularly in Australia, can come from many different ethnic groups or ethnic backgrounds. So traditionally, this was a condition associated with patients who are from African American descent, so often from Congo, many of the West African countries, for example, Zambia, etc. But now we're seeing increasing incidence, and about a third of our patients at the Children's are from Middle Eastern families, and also a really high incidence in children and patients affected in India and the subcontinent. So one of the reasons newborn screening is important is that some of our efforts in the antenatal setting to talk to couples and think about whether they may be at risk haven't necessarily allowed us to detect all of the cases in that antenatal setting. But what I would say to you is knowing some of that information is important. Being able to make a note on the newborn screening card in terms of what the country of origin is for the parents is helpful. Certainly if they know that they have a family history of someone affected by sickle cell, or if that they're known carriers in the family, or if in fact if the parents have been tested. So often some of those countries with really high incidence, couples will, part of their international sort of screening program is couples are tested before they marry to see if they're at risk, because both couples are carriers. So in the carrier state, this is often generally a silent condition, and people without having a very specific blood test may not know that they are carriers. That's the challenge. What we also find, unfortunately, is sometimes our families or our couples who are tested overseas, that testing may not necessarily yield a correct diagnosis. And so certainly we've had babies born where the family or the couple thought they were not at risk. So just to give you a little bit of a background, this is a sickle cell. You'll see there looks a little bit, it's called sickle cell because of its shape. And basically the genetic mutation we find here, this is an autosomal recessive condition. So we know that both patients need to be carriers, and there's a little bit of subtlety or complexity in terms of different combinations of thalassemias or gene changes can cause a sickle cell phenotype or the disease of sickle cell. The most common type we're going to talk about mainly tonight is called hemoglobin SS or sickle SS. The other types that are also important because they cause disease in babies and children and adults is hemoglobin SC and hemoglobin S beta naught thalassemia. So what we find is a single point mutation in the gene for the beta globin chain causes this problem where when patients are unwell, often in the setting of fever, dehydration, temperature change, or it can just happen randomly, the red blood cell changes from that one you can see on the left, the nice sort of disc like a frisbee that can squeeze and go through all the blood vessels and move easily through the body, changes shape to become this banana shape. And the way I explain this to my patients, my sort of, school-age kids, is that having a sickle cell crisis is a bit like shoving a bunch of bananas in a pipe. And then I ask the patients or the kids, what does that do? And they say, well, that blocks the pipe, Anthea. The bunch of bananas blocks the pipe. So the end effect then of a sickle cell vaso-occlusive episode is blood does not get to that part of the body, and that can happen anywhere. So obviously up to the brain, we're worried about some of the, so you'll see the complications on the left there. These are our acute complications presenting as an acute sickle crisis. And then we've got, unfortunately, all these long-term sequelae on the right, which are happening because of recurrent sickle episodes. So if the blood vessel to the brain is blocked, the patient can have a stroke, for example. If it happens in the chest, they have a chest crisis. If it happens in an arm or a leg, they have a painful vaso-occlusive crisis. And these are very severe episodes that often result in recurrent hospitalisation for patients. What we see then down the track, unfortunately, is significant long-term sort of disease that affects, again, all organs of the body. And unfortunately, despite improvements in treatment, patients with sickle cell can have a reduced life expectancy. So knowing about this in the newborn period and getting them onto disease-modifying treatment, as I mentioned, so antibiotics, vaccines, but we also have medication that we use. We also use things like blood transfusion, and then there's more involved treatments, including some of our curative therapies. But the first step in all of that is knowing that the child has sickle cell. So although one of the challenges with this condition is often we may not have very many obvious external symptoms for the patient, and you can sort of say that reassuringly to the families that the children will often not present in the first 6 months of life, but very soon after we have this range of complications, and in our little babies and children they often get swollen hands and swollen feet, but they have a problem with the spleen as well. But getting them onto that treatment is really helping us to try and avoid some of those longer term problems. And this slide just really shows again that sort of a visual of what I mentioned before. So the bunch of bananas in the blocking the pipe, but it has lots of other end effects, including infarction, so blockage and pain, but it also causes hemolysis, and so sometimes babies are jaundiced at the time. This is one of our more challenging problems that we have. So children can present with a very large spleen, and this can be life-threatening, often in really small babies. So this is one of the reasons that we meet these families early. And so our pathway, having had a positive newborn screen, would be to get these babies in before 6 weeks of age, to start the antibiotics, start the vaccines, and start teaching them about some of these complications so they know what they're looking for and how they can best care for their baby. So this is called splenic sequestration. This is another problem I've mentioned before, where they can have a thing called acute chest, which can be very serious and life-threatening. And a number of our children, even down to the ages of 2 or 3 or 4, can certainly have an increased risk of stroke compared to other children who do not have sickle. So we do have treatment. That's the other message I want to give tonight, in terms of if you're talking to families who say, is there treatment for that? So treatment involves those preventative things I mentioned, but also getting them onto some of these medications, so hydroxyurea, and then the longer term, more complicated discussions are about things like curative therapies such as stem cell gene therapy and blood transfusion. But the message here is that there is treatment. And we have very good international consensus guidelines that really help us know what we're going to do with our patients, which is why we want them plugged in. We want them plugged into their sickle cell treatment centre nice and early. Plugged in, by that I mean linked, and learning and working with their clinical nurse consultants and their doctors and their care team. So that slide really represents many of the things I've already mentioned, but we treat sickle cell with that medication, with blood transfusions, and then it's all the other things we do. So getting to know and support these families. Obviously, this is a life-changing diagnosis for many families. And the other reason this is important is that you may find for some of these couples, they've had multiple children prior to the baby that you're doing the newborn screening on. And so our job would also then be to work backwards and test the siblings, make sure the family know, and that allows us to provide appropriate antenatal care for future pregnancies, now knowing that we're going to establish definitively everyone's sickle cell status. So just to mention that one of the important pieces of information that will come from our expanded newborn screening program is that there is an Australian hemoglobinopathy registry, which is going to help us to really keep track. At the moment in Australia, because we haven't been doing newborn screening, we really don't know exactly how many patients we have. And that's really challenging in terms of delivering that care, but also planning our service planning in terms of how we're going to look after these patients. So as I said, when I was the trainee of the registrar, we had about 10, and now we have 100, and that's happened in a reasonably short space of time. So we need to make sure we've got clinicians and health services that will help us plan and know what we need to do to look after these patients. And it also helps us with things like advocating with government and other to make sure that we're getting new medications through the PBS and some of the drug regulatory agencies, etc., to really make sure that we're giving best care to our patients. So these are the centres around Australia that are part of that registry, and our newborn screening program, with your help and assistance, is obviously going to feed into making sure we know how many patients we have. So that's our exciting, this is a slide that I used very recently at a presentation to a group of haematologists, but then we know that Victoria has been the first state to go live with this program, and the other states are all due to come on board shortly. So then across all of the states, we will then have a capacity to make this diagnosis and really help those families and get their babies linked in with a haematologist and a centre. So in order to look after these babies and children well, we need to link them in with what we call a comprehensive care centre, because we know that being linked to a centre who have some expertise with sickle is really important for long-term outcomes. Important to make sure that the families can get the care they need, they can get the education, which starts at that very first visit, at that 6-week visit. So when you're talking to families, if they have a positive screen for sickle, the steps that we will take is to be in touch with the centre where the pregnancy was managed to see if we know what the background situation is for the parents. So being an autosomal recessive condition, we're expecting both parents will be carriers if they have been tested. We'll use that information plus the information from the newborn screen to then make contact with the family to ask them to come in and see us. And we're obviously not in the business of trying to get new mothers to bring tiny babies into clinic when they don't need to be there. But if we are, very suspicious that that's an actual, that we, that's the diagnosis, sickle cell disease, we do want those babies in seeing us, making that really important connection by that sort of 6-week time frame to start them on the antibiotics. So this slide is just to remind me that those sort of pathways, those comprehensive care pathways where we're linking with national guidelines is important. This is a group of clinicians who are in all the different states, but a number here in Victoria who will be involved in looking after these babies and families. As I said, it'll be coordinated through what we would call a sort of comprehensive care clinic. So that would be here at the Children's or at Monash Medical Centre in Victoria for children. And then for adults, there's Monash Medical Centre and the Royal Melbourne, and then a couple of other sort of satellite centres is where the care is provided. But we also work really closely with our patient advocacy group. So that bottom slide is celebrating International Sickle Cell Day, which takes place in June every year. And a number of our children in that photo that you can see who are linked in with our services are out with that treatment algorithm. One thing I was just also going to briefly touch on is, as you may remember from Rhonda's slide, and what we may go into in a bit more detail with Mercy, is that when we do the newborn screening, practically what we're looking for is an absence of a thing called hemoglobin A, which is one of the sort of hemoglobin chains, and that's what we're looking for in the first tier testing. Although sickle cell disease is our target disease where we need to get those families in at the 6 weeks, we will also pick up children with beta thalassemia major. That's an associated condition, so again called a hemoglobinopathy or a thalassemia, where a different genetic change also affects the beta hemoglobin chain. And these children have a different presentation and a different condition, but it's also a major, what we call a major hemoglobinopathy requiring treatment. So for beta thalassemia major, these children and babies from after 6 months of age again present with a falling hemoglobin or with anemia, because they're unable to keep up with producing enough red blood cells to keep the hemoglobin at a normal level. And so these children have a different presentation where the blood count will just continue to drop as they get older. If that's not addressed or if that's unknown, they can become obviously unwell with problems like poor growth, failure to thrive, cardiac failure, and a number of other conditions. So this condition, in finding this condition in a way as a sort of not byproduct's the wrong word, but as an outcome of screening for sickle cell, finding this condition will also be identified again by the group of clinicians looking after these patients, and we will also see or be able to identify and support these families with the condition of beta thalassemia major. They have a different treatment, so patients with beta thalassemia major who are transfusion dependent would need to go on to a chronic blood transfusion program, which allows them to grow and thrive and be well. But the onset of needing to do that is a bit later than the sickle cell group. So that may certainly come up as a point of discussion for families reading the information about the introduction of newborn screening. And similarly, so blood transfusion therapy is the treatment really for beta thalassemia major, as opposed to sickle, as we discussed, with some of those medications and other factors. But beta thalassemia, a bit like sickle, is also a condition that can be managed with things like bone marrow transplant, and potentially not available in Australia currently, but in the future likely to be amenable to gene therapy. I think that was actually my last slide. So I would now like to hand over to Mercy, who's going to present some of the current changes in the newborn screening program. Thanks, Mercy.
Thank you, India. I'll just share my slides. Good evening, everyone. Sorry for the confusion. My name is Mercy Thomas. As India said, I'm one of the educators and also researcher at the Murdoch Children's Research Institute. So let's look into what changes we have done this year. So the outline of this presentation is I will give you an understanding about the introduction of the sickle cell disease into our newborn screening card, and also understand the importance of the sample quality and why it matters now. And we can also look into the recollection process for the preterm and the sick infants in relation to the sickle cell disease. So what has changed? We heard enough that sickle cell disease has been added to the Victorian newborn screening panel as of Feb 2026. And again, we heard enough that Victoria is the first Australian state to offer the sickle cell disease screening through the routine newborn screening program. So why it matters for us as nurses and midwives? Early identification, it supports timely referral, and the kids can have early treatment and improve outcomes for all the affected infants. And as Andia mentioned, the analysis is done from the hemoglobin identified through the dried blood spot card, and the same sample that we utilize for the rest of the newborn screening as well. So your role is to ensure that a quality of sample. So the quality of sample dictates the success of the sickle cell screening. As such, we all know that nothing has been changed, but now how we collect really matters. What other changes have we done? I don't think many people have seen the new flyer. There is a new look for the flyer. At the same time, with the new look, we have simplified the frequently asked questions. So if the mother, after the delivery, they want to read it, I think it is a bit more from a parental perspective. So it has been simplified. The language has been simplified. And there is an example of the newborn screening card at the back as well. And the inside of the flyer, again, you see that there is a timeline or the process around what does sample collection include, after the collection where it has been sent, and what does the results indicate. If they need a recollection, what does it mean? And then again, the last one is the results that requiring follow-up as well. So it has been simplified in a way that it's easy for the parents to understand. And the aim is to have these flyers available at the GP areas or the antenatal clinics, wherever the parents can pick up this and have an understanding about what the newborn screening involves. So it is less stressful for the midwives in the postnatal area to explain the whole newborn screening for the family or the mother who has just delivered the baby. That was the main purpose of the change of the flyer. So of course, nothing has changed from a timing perspective. So it remains as 36 to 72 hours after birth. But ensure that if you collect the samples outside of this window, it must be clearly documented on the card. This will help for the lab to dictate on the values that they're looking at. And again, the key points that we need to look into when it's sample collection is aim is to fill all the 4 circles. Previously, we used to say, okay, 3 dots are good enough, but the Victorian government has taken off that statement because, of course, more and more screening we are doing, more and more samples we need to, more and more blood we need to analyze. And ensure that the blood is collected to the correct side of the card using a free-flowing, of course, a free-flowing drop, because otherwise, again, squeezing doesn't help. And again, layering also doesn't help, because the key message here is we are analyzing the hemoglobin. So multiple layering can again affect the analysis at the lab side. The other point here is complete one circle before moving to the next so that we can ensure that at least one circle is completely filled. And again, avoid excessive squeezing. I'm sure that I'm talking to the converted. We all know that this can lead to the tissue fluid contamination of the cards. So if the collection is difficult or traumatic, please send the card to the lab. The lab will determine if a recollection is required or not, and it does not fall on your shoulder to determine if a recollection is required. So why the sample quality matters even more now? Again, we all know the drying and the transport process, making sure that we dry the card for 3 to 4 hours away from heat and also away from direct sunlight if you're collecting it from the home settings. A paper envelope only, not plastic, and making sure that it is dried before you send it, and sent daily. To not delay sending the card to the lab. Every 24 hours, the sample sending process needs to happen at the clinical area. So as we mentioned earlier, with more conditions being screened, we need adequate blood volume, and that is essential, and I cannot stress enough. So more dots filled, it's important for now to analyze everything. Again, I've highlighted there about the cost of a poor sample. Of course, it delays the diagnosis. You may have to prick the baby again, and the family anxiety peaks again if you're pricking multiple times. And of course, extra workload for you as staff and also for the department. So the key message here for the sickle cell disease, as we mentioned, it uses the hemoglobin. So clotted, layered, or underfilled cards, it directly compromise the lab's ability to interpret the hemoglobin pattern accurately. So we mentioned enough, a poor sample is not a minor issue. It can mean a missed or a delayed diagnosis of a life-altering condition. And an example of a good quality sample I've given here. I've seen midwives collecting this beautifully, especially at the place that I'm working, Royal Women's Hospital. They're really good at taking these samples. And some of the poor quality samples that we get at the lab, you can see there is layering here. But again, sent to the lab because we need to test everything. But ideally, we need a good quality sample to analyze it better. What's next here? Yes, again, in relation to sickle cell disease, preterm babies and sick infants, the pathways are different. So of course, for the routine preterm babies, we collect the sample at 36 to 72 hours. And we also may have to have a repeat at 4 weeks of age or at discharge, whichever comes first. If the sick preterm baby has got blood transfusion done, we need a sample to be collected before transfusion, even if it is under 36 hours. So then another sample at 36 to 72 hours, 1 week post the last blood transfusion, and then again at 4 weeks of age or at discharge, whichever comes first. When you look into the sick preterm infant, term infant, and if they have got a blood transfusion, the same principles apply. We need to have a pre-transfusion sample, even if they're under 36 hours. We need to repeat at 36 to 72 hours and also at 1 week, but we don't need a 4-week sample because they're term infants. So why this matters for the sickle cell disease? Transfusion can mask the baby's own hemoglobin pattern, and that compromises the sickle cell disease screening accuracy. So pre-transfusion sampling is critical. You are all familiar with this protocol. This is something that's been implemented a few years ago. What we have changed or what's been added is, it's not clear in here, but when you go back and check your protocol there are some references here, what it means by 1, what it means by 2. So that's been clearly marked at the bottom to say that 1 is like, what do you mean by blood product? The number 2 is a follow-up recollection is required if the baby has to had a transfusion done, and that will be clearly noted in a recollection letter sent from the VCGS. And I think I've got an example here. So this is a letter that comes from VCGS to the hospital or wherever the newborn has been delivered to indicate that we need a recollection. So the health services will take the responsibility to contact the family and ensure that they have a recollection done so that we can screen again for sickle cell disease here. So that's how the letter looks like, but I've faded up all the confidential details here. So what's the take-home message here that you want to take from today's session? Ensuring that we collect samples at the right time, That is, of course, 36 to 72 hours whenever possible. But if it is outside of this window, please ensure that it's documented on the newborn screening card. Again, right sample. That means we need to aim for filling up all the 4 circles. Try and have no layering. Ensure that we dry the newborn screening card correctly and send them in a paper envelope within 24 hours. So if we can do that, then the rest of the process can be facilitated by the lab and the referral can be done to the clinical settings. So the last message is right recollection pathway. So follow the preterm or the sick infant flow chart and making sure that we need a pre-transfusion sampling. And it's critical now as we have introduced the sickle cell disease on the panel. That's it from me, and hopefully Rhonda can open up for questions.
Thank you. Mercy, please stay. Thank you for a lovely presentation, and Anthea's back, and thank you also. We have some questions in the panel discussion, and a couple have been sent as texts, etc. So I'll go through those in a orderly fashion. And the first one is to Anthea. If the first child has sickle cell disease diagnosis, what is the risk or chance of the second child having sickle cell disease too?
Thanks, Rhonda, and thank you for the question. So this is an autosomal recessive condition. So the risk for each pregnancy is 1 in 4 or 25%. And it's completely independent with each pregnancy. The first child can be affected or unaffected, but again, the second child has a 1 in 4 or 25% chance. So we have some families where we have multiple children or siblings affected, some families where we have very small numbers, but each pregnancy is a 1 in 4 or 25% chance. So that's that situation I mentioned before where you may have a family and this is not the first child and this is a surprise diagnosis after the newborn screening process has played out. And then obviously we're going to, as the clinical team looking after that family, going to go back and test the other children. Sometimes children do present later in childhood. So many families will say, well, why didn't we know? And there is variable presentation. So certainly we would still go back and screen those children, and then obviously make sure those parents are appropriately screened so that we've done all that confirmation work. Yeah.
Thanks. There is another one here that's come through. I'll stay with you, Anthea, for a moment. What is the incidence of sickle cell disease in Australia?
Well, that's the million-dollar question. Thank you for the question. This is what we don't actually know because we haven't had newborn screening. We don't know the answer to that question. So really what we have is sort of prevalence in terms of what we know for right now, but we don't actually know that number, which is why it's really difficult. And that's the hemoglobinopathy registry that I mentioned is working on exactly that, but newborn screening will go a long way to help us establish that.
Okay, thank you. I will head over to Mercy for her tricky question. Will the VCGS flyer be available in languages other than English?
It is available in the old format, I believe, isn't it, Rhonda? And I think there is a plan in place to establish a process to have multicultural implementation of all these flyers.
Yeah, I might help you a little bit with this answer also. We are going to look at changing the flyers over for languages other than English and review that. We actually had a forum with other newborn screening laboratories a week ago, and it was brought up, and it was also brought up about Aboriginal and Torres Strait Islander languages. So until we change over to the new flyer, the old flyer or brochure, as we call it, will be still available on the website in all the languages. It is not so different in content. We have really just modernized it. We've taken out a list of conditions screened, and you could see from my earlier slide that we're changing so quickly that having a flyer can become very out of date quickly with as we're implementing more and more, but the flyers in the other languages will still be relevant and they'll be still available to download and use until we get to an updated version, which is a project probably for later this year or early next year. And Mercy will really enjoy leading that, probably. But yeah, thank you for the question. I think that's really important. I am going to throw open a question on English as a second language, which is not sickle cell disease related. But I'd like, Mercy, if you could talk to refusals, please, and the problems that, and the really importance of informed consent and actually really engaging with the parents for collections and the refute. Yep.
Thank you, Rhonda. Yeah.
Thanks.
Recently, we did an audit of all the refusal rates, and it is alarming to see that the refusal rates are creeping up. It used to be roughly like around 0.2% up until like around 2020, which we can all relate to COVID time. But after COVID, the numbers are just going up from 0.2 to 0.6 and 0.8, and now it's crossed more than 1%. So 1% of Victorian newborns, if you look at it, is more than 800 babies. So 800 babies are not being screened. And sometimes it's hard to understand that from the newborn screening card, why they're refusing it, because of course we're not asking that question. But if they are refusing it, make sure that that's documented on the card, and the card can still be sent to the lab so we can still track and monitor that. But however, again, with the topic on the different languages, we are not sure whether they are able to understand the importance of newborn screening or whether they are wanting not to have screening and not understanding the impact or the consequences of not screening. So there is a lot of variables that we're still not sure, but however, we realize that there is a lot of babies not screened out there. And recently we identified there is a CAH child who has not been screened, but later came diagnosed to have CAH. And it was a bit delayed, but the management was intense for that baby, and the family realized the importance of that screening at that time. So what we could do, I believe from nurses and midwife perspective is like reinforce the message and utilize all your resources around to help them understand the importance of newborn screening. And if they still decide to refuse, of course, we have to respect their decision. But however, I think we have a responsibility to ensure that every newborn has the right of service.
Thanks, Mercy. This is a bit of a passion for us. So that brochure question led into that. So there was a little bit of a distraction, but straight back to Anthea. There's a couple of questions. This one's definitely for you. Have any babies been identified since starting, and what is the follow-up?
Thanks, Rhonda, and thanks for the question. So yes, we have identified babies since we've started screening. And in actual fact, we have had families who likely knew that they were at risk, but didn't necessarily have testing done prior, or the team looking after the pregnancy were not aware. And so having that identified on newborn screening has certainly got the babies to come and see us, as would be our follow-up plan. So the answer is yes. The follow-up plan, as I mentioned, so once it's identified, we do a bit of background finding out if we have information from the maternity service about what the couple's risk would be and what if the parents have been tested, what the carrier status is, so we can put that information together, and then we call those families and explain to them that they've had a positive newborn screen and we'd like them to come in and meet the team. We then obviously go through the process of the confirmatory testing, which involves sort of DNA or genetic confirmation, but in the meantime can institute the early treatment, which can obviously always be stopped if it's not the case, but the confirmatory testing so far has all confirmed our findings from the newborn screening. So they've been linked in that way. Yep. One thing I was just going to add to my question before. So 1 in 4 is the chance that we have a baby affected with sickle cell disease. So that's the SS or the SC or the S beta. And that's the same risk for beta thalassemia if we have a couple where both partners are beta thalassemia carriers. For the other scenarios in that combination where both parents are carriers is a 1 in 2 or 50% chance that the child will be a carrier of either the sickle or a carrier of beta, and then a 1 in 4 chance that they will be unaffected. That's the genetics.
Okay. Thank you. All right, I was about to go to a top question, but I'm going to go down to the one that's just come in, which is a comment. A comment, and Mercy or Anthea might like to answer this. This is anecdotally, I've personally had a family decline newborn screening as they didn't want their child's blood info being kept by the government. Number 2, a father adamant there was nothing wrong with my baby. Why would you test? Why would you test? Both were migrant parents. Not sure whether you can talk to that, and you can't answer it. It's a really hard answer, Mercy, but you might, yeah. Do you have any comments?
Yeah, I agree with the person who has written this. We face a lot of scenarios like this because they are sometimes from where they're immigrant parents in the part of the world they're coming from. This is not a part of their routine care, and they question that, and they realize that the baby is normal, doesn't look any sort of illnesses. Why are you collecting blood? So, of course, again, you can utilize the flyer. That's one form of resource. Again, if you have the right language to give it to them, that's another. Or using the interpreter services to explain to them. This is a routine procedure that we do, and the importance of screening. So we, from a health professional perspective, I think we try a level best to explain the importance, the impact of not screening, the consequences of not screening, the benefit of screening, and it is a public health initiative, and almost 100% newborns are screened in Victoria or across Australia. So we can keep reinforcing the message, but I can understand from the message that's been given, still sometimes if the father is the dominant person in the family, they can keep reinforcing that message as well. So my best advice is try a level best to explain everything, utilize the resources around you, utilize the interpreter services to help them understand from their language perspective. And that means at least you feel like you've done everything that you can. Anthea, you have something else to say, Anthea?
I was just going to say, I think it's, what we want to do is reassure families that the information and the samples we're taking are being used explicitly for the things that they're sort of consenting for with the newborn screen, which is for screening for the range of conditions that we have included. And so that's sort of to answer that question about the government sort of storing the samples. I think we say that, the importance here is to screen for these conditions that we know have either, significant, potentially life-threatening complications, such as the sort of CAH situation where we know babies can get very unwell very quickly if we don't have that diagnosis. And for the case of sickle cell, we're saying that linking them in with a team that treats this condition, allowing them to start on preventative health measures, can be life-saving. And we don't want their baby to become unwell and to have that situation where their presentation is because the baby is unwell. And getting linked in with the treating team and starting on treatment is really important to keep their baby well. We know that in countries where there isn't screening but a really high rate, so many of the African countries where there isn't a screening program, the child mortality under the age of 2 with sickle cell is almost 90%.
Wow.
We that would not be the case in metropolitan Melbourne, for example, because obviously we have different sort of environmental conditions, but it is a condition that is life-threatening in small children if we do not know that that's what they have.
I'll come back to you, Anthea. I actually have a question for you out of my own curiosity. But Mercy, one for you. and possibly a little bit for me. If screening was done before 36 hours and was missed to repeat again in 72 hours, how would this affect the accuracy of the test result?
Do you want to answer that, Rhonda? I think my understanding is like you still can collect the sample. I think the pre-transfusion sample at 36 hours has been done, but then if you miss that, collect another sample when you actually can. Is that right?
Yeah. The sample before 36 hours will be fine for the sickle cell disease screening. We need something pre-transfusion. So we don't have the transfused blood mixed in, because the transfused blood might suppress the hemoglobin S and we mightn't see it, and we'll see a lot of hemoglobin A, which is normal, but in our babies with sickle cell disease, we would expect no hemoglobin A. So that pre-transfusion and early sample is fine. We expect a lot of hemoglobin F, but it's the pre-transfusion that's important rather than the timing. The timing here, that the 36 to 72 hours is ideally for some of our other tests. So even if you took an early sample, we will chase you for that repeat sample because we need it for our metabolic conditions in particular, and our TSH we need it for also, so that we can give an accurate result and an interpretation of our screening result. But for sickle cell and also for SCIDS and SMA screening, and it's all fine, that early sample, so we can tick the box for an accurate screen. Okay, if that makes sense. Anthea, I just thought it might be of interest to people. So you said there was a 1 in 4 chance of getting sickle cell disease, which means, and there's a 1 in 4 chance from 2 parents of not having any sickle at all, but then there's a 2 in 4 chance of having sickle cell trait. So that's quite a high incidence. Is there any clinical worries about sickle cell trait, and why is it so prevalent? Why has it been maintained?
Yeah, that's an interesting biological question. So the gene has persisted because traditionally there is a relative resistance to malaria infection from having the sickle cell gene. So it's harder for malaria to get into red blood cells if you have the sickle gene. And that gene has certainly persisted, particularly in those parts of the world where malaria is more common. So that's why the gene has sort of persisted, for example. So that's and can you just remind me, Rhonda, of the first question? What is there any implication of being a sickle cell carrier?
Yeah.
So I think the simple answer for that is no. So that's why parents may not know they are a sickle carrier, because they will never have necessarily ever had a symptom. So sort of practically and functionally, the answer to that is no. There's very rare situations, sort of case report situations in extremes, like on the top of Mount Everest or an unpressurized air cabin, and a few very random things where patients can get some sickle cell symptoms. But practically speaking, most parents who are carriers, the reason they don't know is they have absolutely no symptoms. And also sickle cell in particular doesn't show up on a regular blood test. So if parents have had just a normal full blood count but not had thalassemia screening or hemoglobinopathy testing, this doesn't affect the size of the red blood cells. It does in the case of beta thalassemia, but the FBE will be completely normal, and it would only be if someone looked at the blood film or the parent had a hemoglobin electrophoresis that then someone would be alerted to know that they were a sickle cell trait, patient with sickle cell trait.
Thank you. that was out of my own curiosity. And I think it's a really interesting component because when we do reproductive carrier screening, we are looking for carriers, as the word said, but newborn screening is different. We're actually in Victoria not looking for the carriers. We're looking for babies with what I would call sickle cell disease or compounded with another form of hemoglobinopathy. So we're right on time, which is magnificent. I love that. I'd like to say thank you in particular to Dr. Anthea Greenway. It's been really enlightening, Anthea, and thank you for joining. Also, thank you so much for all your support and the rest of the team as we've gone about this introduction. And thank you to Dr. Mercy Thomas, also, who we all know and love around here. And yeah, thank you for presenting on the recollections and the why we're asking for a few babies for that 3-month recollection. Thanks everyone for joining, and all going well, this is recorded and will be available for you. And the screening lab is very happy to take questions. Thanks again, and thank you, Swanisha, in the background. Good night.
Thank you. Good night.